welcome, and you're very welcome to join the CMEO briefcase entitled Decisions in Advanced Management of Elbow Pain. As you can see, this is supported by an educational grant from BioWave. I'll introduce myself. I'm Dr. Dominic Hegarty. I'm a pain consultant in pain management and neuromodulation based in the Mount Private Hospital in Cork in Ireland. My training background, I trained in Guy's and Thomas's in London, and I've been involved in the healthcare services of pain management for 15 to 16 years at this stage. I've been involved in the neuromodulation research at our National Institute here in Cork, and I'm the president-elect at the moment of the World Institute of Pain. Today, I want to have two key learning objectives. It's firstly to assess patients using some validated tools to determine the nature of the pain and the best direction to lead your patients through. The second learning objective will be to design a treatment plan using both pharmacology and non-pharmacological strategies, and to see how they can help you make progress in dealing with cases like this in your practice. So let's introduce the case. The patient we will discuss will be Tom, and he's a 44-year-old gentleman who presents with persistent pain for over 3 months, which intensifies when he flexes his elbow and wrist extension. In addition to the pain, he states that he has a weakening of his grip, and he often has a tingling sensation radiating to his ring and his fifth fingers. Sometimes he describes the sensation like his fingers have fallen asleep, and at worst, it's a burning sensation, often keeping him awake at night. He's tried lots of different over-the-counter products, but no significant relief, including anti-inflammatories and agents such as that. He has also, this has reduced some of his pain, but it certainly doesn't help him on a day-to-day basis. From a practical point of view, he enjoyed golf 2 to 3 times a week, but now he's had to stop it because of his ongoing pain. And ultimately, he's in your room and your clinic because he wants you to be able to prescribe something that will get him back away from his pain and certainly back onto the golf course as quickly as possible. So at this stage, I'd ask you just to think about that case and perhaps answer these 5 simple questions and to see which direction you would like to take his treatment at this point. Before we get around to answering some of those questions a little bit, I'd like to ask you to remind yourself of the different types of pain that exist. And this hopefully will help us understand his pain a little bit better and then make good decisions. There are 2 very, very clear groups of pain pathways. First of all is the nociceptive and the inflammatory one, which we associate with an acute injury, an injury to a stimulus, or an injury such as a sports injury, an arthritis, or mechanical low back pain. These generally involve the peripheral nervous system stimulating onwards. And as you know, a lot of these pains will settle down reasonably quickly. On the other extreme, you have neuropathic pain. This is one where there's a more defined nerve damage or a neural damage, irritation of the nerve on a constant basis. This would be associated with conditions such as neuralgia, post-traumatic neuralgia, carpal tunnel disease, radicular pain, or perhaps even sciatica-based features. Again, this involves peripheral and central components to it itself. And the common pathway, if you like, or link between these 2 groups of pain strategies is central sensitization. And depending on how long an individual has it, perhaps the severity of the pain that they're experiencing, you begin to see how much of the central system becomes dysfunctional. And the further people have the chronic pain, the more and more these symptoms change, and they become less and less focused over time. So it's not surprising that an individual who starts at one level of pain may develop onto fibromyalgia, long-standing neck and back pain, and basically their whole impact on their life is influenced because of the central effect of the pain itself. There's a few reasons why Tom in this case actually may have some neuropathic-based pain. The clinical presentation of neuropathic pain has maybe 3 or 4 key elements. Paresthesia is one of them, and features such as tingling, pins and needles, electrical activity, even itching and intolerance to temperature are very clear features that patients will tell you about if you ask them properly. Allodynia, which is the definition of when a pain arising from a stimulus that isn't usually hurting them. For example, cotton wool shouldn't hurt, and sometimes it does. Hyperalgelia is a situation where a painful stimulus becomes even more painful. This all reflects central changes in the pathway that we've discussed. Now, there's no single finding or no single sign that's diagnostic of neuropathic pain. So this is where you have to combine the history, the description, and some degree of assessments. And this may be features such as looking at the state of the injury. Is it particularly inflamed? Is it sore? Has it got a range of movements that are an issue? And sometimes you can integrate sensory examination into this area. Pinprick, for example, light touching, von Prayer testing, for example, is an opportunity to do this. But also there's opportunities to do electronic testing, such as quantitative sensory testing. It depends on what people have access to at that period of time. But these can be all very useful ways of defining what neuropathic pain is. In fact, this has been looked at in great detail over a number of different assessments. And we've highlighted maybe 3 or 4 areas here. Firstly is the pain detect. It's a very simple bedside assessment that you could ask patients about. It relies on their input with no physical examination. So you're listening to the way they describe the symptoms themselves. It's got a good sensitivity and specificity. The DN4 scoring system, it does include some physical examinations. It's a combination of 10 very simple bedside questions that you can examine, and a score of 4 out of those 10 would indicate neuropathic pain is very likely. This is something I'd use in my practice, for example, very easily. There's a little bit more advanced one, which is called the Leeds Assessment of Neuropathic Symptoms and Signs. This is a little bit more difficult to do. So it's a little bit more in the research world rather than the bedside component to it. It takes a little bit more longer and time to go through itself. And here again, examination is an important component to it. And traditionally, we talk about pain scores. We talk about a scoring system of 0 to 10, for example, or alternatively, we can ask an individual to mark their position on a straight line that doesn't have any numbers on it. Both of them are equally good. The evidence is that both of them can work very well. So whichever is your preference can be very useful. Pain scores are only good for a couple of reasons during either at rest or activity, but more importantly, the change is an important aspect to it. So it's important to get that figure into your notes if at all possible. So let's return to Tom's case. Based on the examination when he's with you, you determined that he's got pain, but it's in a distribution of the ulnar nerve. You've identified that he's got an intensity or sensitivity increase to light touch. And when you check the function using the von Frere monofilaments, which is a very light mechanism, you see hypersensitivity radiating down into that area itself. So now we have the physical finding as well as a story or a symptoms that begin to match. So now with this new piece of information, I invite you to look at your diagnosis at this point and have a look at these choices and see which of these you might now take Tom's treatment down. Let's look at some of these agents, not in great detail, but just as to overview them for the benefit of discussion today. Anti-inflammatories or non-steroidal anti-inflammatories are very useful. They deal with that element of pain, the inflammatory component, very useful in the early phase of it when the mediators at their highest. So as time goes on, they become a little bit less useful. We have a whole range of issues, of course, with non-steroidals, from cardiac safety, GI safety, how long the dosages, how much you're going to give them over a period of time, and how long is too long to be on a non-steroidal. Each individual can respond in different ways, so you need to be very alert to this element. And if there's any ambiguity, you may be better to steer away from them. Opioids have something that have been used traditionally to try and solve pain because mu receptors are designed to deal with it. But we do have significant issues with dependency, with escalating of the dosages and addiction. And the evidence now very strongly in the literature is that in terms of chronic pain, being on an opiate long-term is not good practice, and it needs to be certainly curtailed. So any use of the opioid is very short with specific goal sets. Topical agents, we've just chosen 2 here, the lidocaine or capsaicin agents, can be useful. They may deal with some of those neuropathic systems, neuropathic pain that you've identified clinically, and can be quite useful in that regard. But again, clear outcomes need to be outlined for your patient in this respect. Other agents that can be considered, and there's again a reason to go on these type of agents, maybe the gabapentinoids, which is pregabalin and gabapentin. The SNRIs can be useful. Tricyclic antidepressants can be useful in certain cohorts, and sometimes combination therapy can be used to your benefit. When you look at the literature on both sides of the Atlantic, there is no real agreement as to what is a first-line medication, what is a second-line medication. There is some experience that comes in. You might find that in certain clinical conditions that agents respond a little bit better, but it also gives you the scope to move among these categories reasonably freely. Sometimes you might find that pregabalin may be not so helpful, but yet gabapentin can be very helpful. So it's worth considering all options at all times. Let's return to Tom, who's still waiting in the clinic for your treatment. He tells you now he has got some relief from an anti-inflammatory, but the pain and the numbness is significantly impacting on his sleep, on his day-to-day function, and on the quality of life. So now we begin to understand his pain a little bit more, I think. He tells us that the side effects were minimal, but the quality of the pain relief is not what he had hoped for. So he asked you the question, is it time to see a surgeon? So you need to think about this. Are you going to refer him to a surgeon? Are you going to counsel him on the next options? Or are you going to think about what you as a pain physician or someone who is interested in managing pain for him can offer him a little bit better? So here are some options, and I'd like you to consider what modalities you would recommend for Tom now. Obviously, this will depend on your experience, but please consider these and we'll see where we go from there. Let's look briefly at some of those suggestions. Firstly, to look at the prescription of a combination of pregabalin and duoxydene, for example. And in my opinion, that's probably not where I would start. I think combining these agents from the off is interesting. It's probably a little bit too unnecessary. I think you're likely to get a combination of side effects and not gain an awful lot from it. What possibly would be considered here better would be to pick one of the agents, starting at a low dose, titrating it slowly upwards, and following those symptoms that he's described. What you might find is a very low dose or regular regime of one of these agents would be very helpful. When you speak of pregabalin, duoxydine, gabapentin, you need to leave a little bit of time for the therapy to match as well. So you may well have to wait 2, 4, or possibly 6 weeks on a titrated regime to see the benefit. Would an intra-articular steroid injection be something we could use in this gentleman? Well, it doesn't really appear to be an option around his joints at the moment. It doesn't seem that it's being driven by that. We have a neuropathic pain that's transferring to the hand. We had some muscle tenderness that we identified, or he identified in the early phase. And he seems like he was able to play golf. So the function of his elbow seemed reasonably well. If you were concerned, you could do some x-rays of the area, perhaps an ultrasound of the joint to see the functional mortality of it. But probably this isn't the way I would go first on this issue. Would you consider regenerative medicine? And by that, I mean platelet-rich plasma or some equivalent, depending on what region you work in. It may have slightly different terms, but essentially, would you work on these items? The answer here is maybe, yeah, that's a very good option. It might help us with the muscular skeletal component to it, the muscle tightness in the hand, perhaps. I don't expect it to help an awful lot with the neuropathic pain that we'll be experiencing. Perhaps it would help reduce the inflammation in the area, maybe loosen up the movement of the nerve tissue, and maybe in that way help the neuropathic element to it itself. So certainly, if you had the experience, it would be well worth considering this. What about looking at the nerve fibers, either using a transcutaneous electrical stimulation or perhaps a peripheral nerve block? A TENS machine has been around for an awful long time. They tend to be better on muscle, so muscle ache and TENS might respond to that. The issue with a TENS machine, of course, is it really only is helpful while it's working. So this gentleman's not going to be keen to use that when he's golfing or when he's working. He'll get a short-term relief when it's working, so he may have very limited benefit, and that might meet his expectations. Peripheral nerve blockade or stimulation, again, could come under what skill base you have. A local anesthetic injection to the ulnar nerve might be very useful. You can use some non-invasive strategies as well, which we'll address in a moment, which could be very useful for these individuals. And ultimately, this would be very helpful. It's probably the area I would deal with around the ulnar nerve at the level of the elbow is probably the most practical approach to capture the whole span of that nerve. Dealing with the ulnar nerve at the level of the wrist would probably only deal with the issues he experienced in his hand, but it could be helpful in its own way. And returning to physical therapy, massage, acupuncture, and other therapies, again, they can be helpful. But I think when the client has come this far along the pathway, he's not going to be satisfied, and you're certainly not going to make that 50% reduction that you think would be useful at this point for him. So I think there's a role for this, perhaps, but just not yet. Perhaps on the rebound, when you're beginning to get better, perhaps when you're reducing your medication, there will be a tremendous use for it at that stage. Let's just consider the peripheral nervous system as a window into the pathway of dealing with this gentleman's pain, as an example. We do know that once the nerve fibers are irritated in the periphery or somewhere in the peripheral, they cause dysfunction and they lead to amplification within the pain pathway. And this subsequently drives the activation in the dorsal column and going on forward to the central sensitization at a higher level. That's ultimately what you want to reverse. You want to reverse this element to it itself. Traditionally, we would have considered local anesthetic and steroid injection as being the gold standard. But now we need to think outside the box. I think bioelectrical medicine has a huge option for us to try and relieve individuals on a purely practical element and certainly reduce the pain. The evidence is becoming that we need to be steering away from just pharmacology at this stage to non-pharmacological options. But more importantly, it gives the individual the control mechanism that they want. Electrical, magnetic, optical, and ultrasound technologies are all available in the market to present individuals with personalized therapies, reducing and often eliminating the need for the drug-centered opportunities, but also giving very quick and useful treatments for the individual. If I can share some information with you, for example, some work we've done on 463 individuals over an 18-month period, we've monitored their progress and we've chosen to use non-invasive techniques such as the BioWave device to generate energy around the nerve fibers in order to stop the treatment. And we found very successfully that many people cut back on their pain medication, but 50% of them were using it on a daily basis. Over a third of them were using it several times a day because it gave them the flexibility they wished. But as time went on, they became more independent of the therapy. And that obviously is a very positive psychological factor on these individuals as well. The equipment that we're using looks at nerve stimulation using 2 high frequency wave patterns that alternate over a period of time. And this is important because trying to get a signal from the external to the nerve fiber revolves around 2 components. The impedance of the cutaneous tissue has to be overcome, and that requires high frequency. And yet the nerve tissue themselves only responds to low frequency. So you have to get the equipment to do this for you. And we've shown that this is a very useful way of doing it, and individuals are very satisfied with it. These are delivered with a pad mechanism targeting the area, and that can be altered as appropriate. For example, this type of strategy could be used to reduce your pain medication by over 50%. We've shown a statistical improvement in the quality of life, mood, and sleeping patterns. And individuals with these can do functional things like move better, walk better, stand better. Overall, individuals continue to use it for a period of time. And I think that's always a very good marker because clients are always going to let you know if they like it, if they're using it. And that's an important outcome marker for us. I think when you look at these type of cases, and no matter what strategy you put in place, be it pharmacological, non-pharmacological, intervention in terms of injections or wearable devices, you should set individual goals for individuals. You should target a 50% improvement or reduction in pain, medication, or just what they're doing on a day-to-day basis. I think it's important to establish that goal. Very often as clinicians, we have a target or an outcome, but the patient's expectations can be completely different. For Tom, in his case, he wanted to go back playing golf. He wanted to be able to sleep better. And as the cases went on and as you were treating things, it became clearer what he was really looking for. And then you can tailor your strategy to meet that. And I suppose this makes the point that there are many ways to deal with the pain. What really matters is the individual gets to the results that they want. For me, peripheral nerve injections and stimulation should not just become as the last resort and not as a salvage therapy. It should become part of the strategy. It should be introduced early. It's non-invasive, it's practical, and individuals can engage with it on a as you need it basis as well. And that gives them huge control. And the psychology of having that control mechanism in the pain world is very important. So bringing in therapy early is important to make the impact that we would want. So ultimately, I would suggest in any situation, in any case, not just Tom's case, make sure you get a clear evaluation of the patient from the beginning. I would very much be focusing on and looking for the language of neuropathic pain. And if you can do that using a validated assessment tool in your clinical practice, you will make a huge impact on screening for these individuals very, very quickly. That coupled with a physical examination or a little bit of sensory testing from just simple office-based elements, you can really establish an accurate diagnosis. And of course, that immediately sets you down onto the therapy pathways very, very quickly. The decisions then to decide what drugs you need or what strategies can all develop and spur from there. Ultimately, I believe a multimodal pain strategy is the one that's going to work best. We have not got that one single bullet that's going to solve the issues for everyone. So therefore, we need to think about introducing different strategies earlier rather than later, giving clear outcomes, giving clear targets, and then acting upon that target if that doesn't meet your personal goals or the patient's expectation is a very important part of the overall treatment strategy. And I think in this type of situation, if you were to take that approach with the scenario we've just painted here via Tom's injury to his ulnar nerve, it's very likely he will achieve 50% relief very quickly. It's very likely he will be off his oral medication in a very short period of time and hopefully back on the golf course. So from my perspective, I hope you've learned some new information about how to deal with these situations going forward. I hope you've enjoyed the presentation from the CME briefcase entitled Decision Points in Advanced Management of Elbow Pain. And I'd hope you'll be able to bring some of that into your clinical practice. And I wish you the very best of luck. Thank you.